Hello, this is my great pleasure to be with you today to discuss the topic of the sepsis phenotype and endotype. And the question is it the way forward? This is my disclosure slide, none of which is really relevant for this presentation. Sepsis is in fact a three-act play. Traditionally, we see sepsis as the expression of interaction between the host and the pathogen, but we should not forget the environment that plays a very important role. Sepsis is a syndrome, but there are many phenotypes. What is a phenotype? It's an observational characteristic or trait of an organism or a disease, which is produced by the interaction of the genotype with the environment. The endotype, and this is a Wikipedia definition, is a subtype of a condition which is defined by a distinct functional or pathobiological mechanism. And as you can see on the right part of the slide, phenotypic resemblance does not imply endotypic similarity. Now, what can we do in the field of sepsis? This slide shows on the left part here how heterogeneous sepsis patients are. We can enrich in terms of prognostic if we would like, for example, to group patients with low risk of mortality and patients at the bottom part here with high risk of mortality. But we can also enrich in terms of prediction, particularly when we are interested by a pathobiological pathway or mechanism of action to group patients with a similar underlying mechanism. Here, I've displayed one slide that tried to identify within a subgroup of pediatric septic shock patients based on a genome-wide expression profiling, patients that looks the same. There is a derivation cohort of about 100 patients and a validation cohort of 82 patients. Based on sets of 100 genes, what the author, Hector Wong, and his colleagues did is to classify patients in 3 subclasses based on this 100 genes. And these were pediatric patients. As you can see here on the right-hand side, this is a follow-up study that showed that subclass A, based on this 100 gene, was associated with a higher mortality. Dr. Tim Sweeney and his colleagues have used a set of data available in the literature based on transcriptomics data. These are 14 sets, including 700 patients, to define sepsis subtype, as you can see, based on functional analyses of these data sets. And they validated in 600 patients. And they were able to find 3 subgroups or subtypes of patients with either an inflammatoropathic, an adaptive, or a coagulopathic phenotype associated, as you can see here, with different level of mortality, coagulopathic having the highest mortality. So we go here into subtypes. Oh, sorry, I have to go back one slide. If I can do that. Yes. The next study is a study by Dr. Davenport from Oxford with Julian Knight that used the phenotype of community-acquired pneumonia with organ dysfunction, so sepsis patient. They used genomic-wide transcriptomic data on peripheral blood leukocyte to try to identify sepsis response signature. And they identified 2 signatures, SRS1 and SRS2. And as you can see, both in the discovery cohort and validation cohort, the outcome was worse with SRS1 which could be defined by 7 genes, and the signature was an immunosuppressive signature, T-cell exhaustion, and metabolic derangement. Using this kind of information, other colleagues try to go ahead and identify also response to glucosteroid therapy. On that slide, I showed our own data, trying to go one step further using a functional polymorphisms of a pro-inflammatory cytokine gene, MIF, as a predictor of outcome in a subgroup of patients with well-defined sepsis phenotype, meningitis here, and even more precise due to streptococcal pneumonia. As you can see here, based on the MIF genotype, here you have 2 genotype associated with higher level of MIF proteins in the circulation. You can see that when you have the high MIF expression allele being present, here the G at position -173, the mortality goes up significantly when we switch from the G to the C. And when we use the CATT microsatellite here, the same is happening. With the 7-7 genotype, the mortality is 3 times higher than with any other genotype. And this is associated with high level of the protein in the cerebrospinal fluid of these patients. So as you can see, we can predict outcome based on this genotype. The colleagues from Oxford used this SRS1 signature or SRS2 to try to predict the response. And as you can see, depending upon the signature which is present, their response to hydrocortisone vary. With one signature, there was no impact of hydrocortisone versus placebo. These are data derived from the Vanish randomized trial, whereas in the other signature, you see that if you use hydrocortisone, there is a detrimental effect, which is statistically significant in terms of outcome. So here, one example of this immunosuppressive signature being important. Colleagues from the Netherlands collected data from their MARS study. These are patients in the ICU in 2 university hospitals in Amsterdam and Utrecht. This is the 2 diagram on the left and in the center. And they could, based on 140 genes, identify various endotype that they call MARS1 to 4. And as you can see in this discovery cohort of more than 300 patients and validation cohort with 216 sepsis patients, that the MARS1 endotype was associated with a worse outcome. And they validated their finding based on another cohort from Oxford. These were the community-acquired pneumonia patients. Again, MARS1 having a worse outcome. And they could define a ratio of 2 genes that might be of clinical use. Now, one of the nicest study in the field is the study from Chris Seymour that appeared in JAMA. And what they have tried doing using 2 very large cohorts of sepsis 3 patients between 2010 and 2014 was try to identify sepsis clinical phenotypes, and they defined 4 designated alpha, beta, gamma, and delta, and that were shown to correlate with biomarkers and mortality. And on the right-hand side, you have the chord diagram that showed the relationship between the 4 phenotypes and the clinical characteristic of the patients with cardiovascular, hematology, hepatic, inflammatory, neurological subtype expressed on top. And the width of the ribbon that associated between the phenotype and the clinical characteristic shows the degree of association. And they also analyze an association between, in various clinical trials, between the amount of patients with the phenotype and the outcome. On the next slide, they showed in the derivation cohorts, there was an increasing mortality going from the alpha to the beta, to the gamma, and to the delta phenotype, that they reproduce at least in part with the delta phenotype being the worst outcome on day 28 mortality in their validation cohort, which is twice as large as the other one. So again, a clinical phenotype here associated with outcome. And we have a collapse here of the 3 other, but the gamma is still very well associated with poor outcome. So what can we do in the future? This slide shows what we can do at present. We can get clinical data. We can get information from technology, from omics technology about various biomarker and parameters. We can use bioinformatics and immunological expertise to try to identify either phenotype or endotype from patients. And the next slide shows what we are presently doing in Switzerland. This is a personalized Swiss sepsis study that has so far enrolled 6,000 patients from the ICUs of the 5 university hospitals, where we collect in real-time data about lab tests, clinical parameters, as well as more specialized tests. This is put in data warehouse. We do algorithm, artificial intelligence and machine learning to try to define the sepsis phenotype. And we are also using omics data to try to define more precisely endotype. And this is a exercise that is going on. So in conclusion, sepsis is a heterogeneous syndrome with numerous phenotypes. We have now to work with well-defined homogeneous phenotype or endotype instead of sepsis, all comers. And the endotype might be the way forward for the future. It defines functional and pathobiological studies which we can use for predictive and prognostic enrichment. And the next step is going to be proof of concept studies. I thank you very much for your attention.